So I'm going to point out some things in alterations in neurological function. So the first thing we'll talk about is migraine headaches. We had a quiz in Socrative in the classroom, and we've been talking about this throughout this unit. So migraine headaches are characterized by being recurrent. It's annoying. Throbbing pain, usually one side of the face or one side of the head, I should say. Patients are going to have nausea and vomiting, photophobia, meaning they don't like light, and then phonophobia, meaning they don't like sound. And they'll have an aura, which is a sensory warning that something's about to happen. Now, if you like, there's acute mnemonic called POUND, and it represents the signs and symptoms. So pulsatile, meaning throbbing headache, hours. So a migraine can occur over 4 to 3 days, 4 hours to 3 days. So 4 to 72 hours. It's on one side, they get nauseated, they throw up, and it's disabling. It's due to, or I should say, the causes are stress, lack of sleep, alcohol, sweeteners, artificial sweeteners, hormone levels. It happens in women maybe around their menstrual cycle. People that eat too many nitrates or tyramine foods. So remember what tyramine foods are and nitrates. No, they shouldn't eat caffeine. Intense odors and bright lights, so they get like sensory overload. And weather and altitude changes can also cause migraine headaches, or triggers, I should say, trigger it. So with migraines, you want to teach them to do stress reducing strategies, or use stress reducing strategies. You want to promote a headache diary, so encourage your patient to do that. Reinforce teaching with over-the-counter meds and herbal products. So there's something called feverfew that people with migraines can take because it's supposed to help with their headaches, but it also can prolong bleeding time. So it can result in bleeding. So that's, you want to do some teaching with that. Maintain a cool, dark environment when they have the headache. Head of bed should be 30. They should use abortive therapy when they have the aura. Okay, so usually it's like a sensory aura. So they might see spots, they might feel numbness and tingling. That's when you want them to take the abortive therapy. So that's the triptans. Now, don't give triptans to anybody with cardiac problem, like they've had an MI in the past or they have hypertension, because it could cause ischemia. Also, they can take NSAIDs, acetaminophen, antiemetics, and ergotamine is another drug, and it has caffeine in it actually. So it's kind of weird. They should avoid caffeine unless they get the migraine, and then they take medications with caffeine. Now, the other things that are preventative are anticonvulsants, beta blockers like propranolol. I know a lot of my patients have been on that for migraines, and antidepressants. The other thing that's not written there is Botox. I had a friend that used to go every 3 months and get like Botox. It was like a band around her head, and she would get lots of Botox shots there, and the insurance covered it because it helped with her migraines. All right. Cluster headaches, usually triggered by ETOH and smoking. All right, let's talk about seizures, because you need to know what to do when somebody has a seizure. Lots of causes of seizures. We're talking about, in this unit, TBI, stroke, conditions of neurological conditions. So we're going to be worried about seizures in most of the things we're talking about. Okay. So seizures, the triggers, if people has a seizure disorder: extreme exercise, excessive stress, hyperventilation, because remember that causes respiratory alkalosis, which can cause you to seize, fatigue, drinking too much, alcohol and caffeine, and flashing lights. That's why when somebody has an EEC, they may flash lights to try to evoke seizure. All right, some seizure terminology. A means without, tonic means stiffening, clonic means rhythm jerking. Autonisms, you may hear that term. That means like repetitive motions like lip smacking, okay? we're going to just talk about generalized seizures because usually what I've seen, except when you get to peds, this might be a little bit different. But usually I see most of the med-surg questions testing on grand mal or tonic-clonic seizures, okay? So you're going to need to know what to do in that situation. Now, seizure precautions. Make sure you always have an airway by the bedside if somebody has a seizure disorder or is at risk for seizures, because you don't want to be in an emergency situation and not have everything you need. You need to make sure the suction is set up and working. This is my pet peeve. I worked in PACU a long time, and the first thing we always did when the patient left, we set up the new suction for the next patient and made sure it was working, okay? Because you don't want to have to do that in emergency, especially as a new grad, because it's not that easy to put together, especially when you're nervous, okay? You want to make sure your IV line is patent. Don't wait till 3 o'clock in the afternoon to flush your line. Make sure you flush your lines early and make sure they're working. You need oxygen nearby, and we no longer use padded tongue blades. So you don't need one of those. If your patient does have a seizure, you want to stay with them and call for help. You want to put them, if they're not on the floor, you're going to place them on the floor on their side. The left side is always the best because it decreases the chance of aspiration. You want to move everything out of the way, keep the patient safe, place their head in your lap, get a rolled blanket or a towel. You need to protect the head. O2, you can put that on if needed, like if they turn cyanotic. You may need to suction, and I don't mean a Yankauer suction during the surgery. You would want to use a flexible suction catheter. Don't attempt to put any airway in while they're seizing, and do not restrain. And then post-ictal, you're going to reorient the patient, PRN. That can last several hours. They get really sleepy, disoriented. Let them sleep, put them on their side, and, several hours they'll be sleeping. All right, let's talk about traumatic brain injuries. The risk factors is being male between the ages of 16 and 36 because males are very impulsive. No offense against males, but they're impulsive and they do risky things. Using alcohol or drugs is another risk factor. An older adult. So older adults usually have traumatic brain injuries or spinal cord injuries due to falls. And the reason they have falls is they can't really see that well. They could have chronic hypertension and they're taking blood pressure medication. It causes orthostatic hypotension. They're weaker, as you age, your muscles aren't as strong, so they're not as strong as they used to be. So that's kind of the reasons. Polypharmacy, they take a lot of different medications. So there's a whole host of reasons older adults have falls. And sports injuries is another reason. So if the TBI is open, we worry about risk of infection. If it's closed, we worry about brain herniation. And so what that means is the brain's coming all down through the foramen magnum, and it's not a good thing. They're probably going to die. So TBI concussion, I talked about this earlier. Glasgow Coma Scale, 13 to 15, may or may not lose consciousness. They're going to be dizzy, have nausea and vomiting, have memory problems if they have amnesia, and they'll be sluggish. Contusion just means a brain bruise. Basilar skull fraction. Okay, so this can happen in a TBI. It doesn't, that means a fracture at the base of the skull. Okay? It's usually diagnosed by CSF leakage through the nose or the ears. So if you have clear drainage coming out of the nose or the ears, otorrhea or rhinorrhea, you want to test it for glucose because your mucus does not have sugar, but your CSF has sugar. Or you're going to do something called halo sign. I'm going to show you what that looks like in a minute. So the drainage can be bloody or clear, so you want to do Halo's test. If you get a choice between Halo and glucose, always pick Halo. And the reason is because if the drainage is bloody and you're checking cerebral spinal fluid, it's going to have glucose because your blood has glucose in it. All right, so basilic skull fracture, they're going to have raccoon eyes, so that's ecchymosis around the eyes, black eyes, and they'll have what's called battle sign, and this is bruising behind the ear at the mastoid process. Okay, so that's one way to identify it. And then if you have somebody with these signs, you would be watching them for leakage of CFS fluid. And this is what it would look like when you put it on a gauze pad. It makes these concentric rings. Okay, so if somebody does have leakage of CFS, you want to manage it. So the head of bed is going to be 30, no pillow because you want CSF to drain properly from the brain. Head and neck in proper alignment. You may put a mustache dressing under the nose or an ear dressing and make sure it's sterile. Never pack the nose or pack the ear, okay? No nose blowing, meaning don't let them blow their nose. No picking the nose. They shouldn't cough or sneeze. No hip flexion. Temperature increases intracranial pressure, so make sure you treat that right away. Make sure your patient is on stool softener so they don't strain, and take care of their pain. All right, we're going to talk about the difference between epidural hematoma, subdural, and subdural hematoma. Epidural hematoma is usually due to trauma to the middle meningeal artery, so right there in the temple region. It's arterial bleeding, so that means it's fast bleeding, and it's characterized by a lucid interval. So the patient becomes unconscious, then they become lucid, then it's your job to watch for a change in LOC, because that's not a good sign. That means they have could have an epidural hematoma. So there's a rapid decline in LOC. They may have nuchal rigidity, seizures, headache because there's blood in the cerebral spinal fluid, and they could have periorbital ecchymosis and a blown pupil on the ipsilateral side. Okay, so if they do have this, you need to call the provider right away because they're going to need emergent surgery. Now, subdural hematoma usually occurs in older people or people with alcoholism. The reason is alcohol and getting old shrinks your brain, so there's more space in between the skull and the dura. So that's why. So they're going to have weakness contralateral side. It'll be diagnosed with the CT scan. The other thing with intracerebral, it's usually due to hypertension. All right, subarachnoid hemorrhage, worst headache of my life. That's what that means. It's due to arterial aneurysm in the brain or an AVM, which is the arterial venous malformation. Occasionally, it's due to trauma. Now, a lot of people have cerebral aneurysms and they have no signs and symptoms. So oftentimes this is going to be a surprise to people if they have a subarachnoid hemorrhage. Okay? Now the signs are going to be decreased LOC, nuchal rigidity, headaches, photophobia, nausea and vomiting, visual disturbances, and seizures. Okay, those are the signs and symptoms, how to recognize it. You want to prevent rebleed because they're going to be at risk for rebleeding 7 to 10 days after. So prevent increased intracranial pressure with all those interventions I've talked about previously. And they'll be put on nimodipine, which is a calcium channel blocker, which crosses the blood-brain barrier. And it prevents vasospasms. So that's why they get that. After a head injury, you're going to look for changes in the LOC. You're going to watch out for seizures and any drainage from the nose. Make sure your pupils are equal and reactive to light. And watch for projectile vomiting and slurred speech after a head injury. All right, to prevent increased intracranial pressure, I'm going to say it again. Patients need to be on a stool softener. You need to keep the area quiet. If they have a fever, make sure you give them acetaminophen, put them on a cooling blanket if it's ordered. Avoid hip and neck flexion. You don't want flexion anywhere, so you're not going to put a pillow under their head. Maintain normal body temperature. No coughing or sneezing allowed. They need to be given antiemetics because you don't want them to retch, right? You don't want people vomiting. That's going to increase intracranial pressure. Head of bed needs to be 30 with the neck in a neutral position. Turn the lights off, keep it low, and administer O2 if needed. We talked about the PaO2 of 60. If somebody has a PaO2 of 60, it's time to intubate. Okay, normal pressure is 10 to 15 of intracranial pressure. Okay, so if somebody does have increased intracranial pressure, you need to know how to recognize it. So the first thing is going to be a change in LOC. They could be irritable, restlessness, they could be lethargic, they could be sleepy. Okay, so those are going to be the first signs. They're going to complain of a headache, have nausea and vomiting, a change in their speech patterns, their pupils are going to change. They could have cranial nerve dysfunction, ataxia, means uncoordinated movements. Seizures are late, and Cushing's triad, imposturing are late signs. So remember, Cushing's triad is the widened pulse pressure, bradycardia, and different types of breathing patterns. Okay, so the breathing pattern is going to change. So again, increase intracranial pressure. These are later, I circled the later signs versus in the other ones are the early signs. So make sure you understand what's late and what's early. This is just comparing increased intracranial pressure with shock. And, the blood pressure goes up with the increased intracranial pressure, but you're really looking for the wide pulse pressure. Okay, generate solutions for increased intracranial pressure. The treatment can be remembered by Mocha Mom. So monitor the ICP, give osmotic diuretics, so mannitol, give corticosteroids, not for TBI though, and not for spinal cord injury. We do not give methylprednisolone, hydrocortisone, prednisone. We don't give any of that for TBI or spinal cord injury. Hyperventilate after the first 24 hours because that's going to prevent the veins from dilating. Give antipyretics because we don't want them to have a fever. Muscle relaxants, oxygen, and make sure the PaCO2 is kept low. All right, now if somebody does have hydrocephalus, which means water on the brain, this could happen if somebody has some type of bleed into the subarachnoid space because the ventricles can no longer absorb it, or I should say the subarachnoid space can no longer absorb the CSVF. Sorry, I'm tired. So they would get this BP shunt, and it goes from the ventricles of the brain to the peritoneal cavity. Meningitis, several different types. So bacterial is going to be worse. Get them on droplet precautions right away. All right, recognizing cues of meningitis. Seizures, high temp. They're going to have the nuchal rigidity, headache, altered mental status, photophobia. So if you suspect somebody has them, get them in a room by themselves and keep it quiet. All right, the meningeal signs include Brudzinski signs. So in the supine position, when the neck is flexed, the hip and knee is flexed up. Kernig's means when the hip is flexed, when the hip is flexed and the knee is flexed, they cannot extend their knee. And how I remember that is they cannot extend their knee is Kernig's sign. All right, so what you're going to do for meningitis, droplet and seizure precautions. Make sure they're on some kind of anti-seizure med too. It's reportable. Prevent increased intracranial pressure and manage it. And we talked about that earlier. Give phenytonin, acetaminophen, and get the antibiotic in if it's bacterial as soon as possible. Brain tumors, all different ways people can have a brain tumor. We've already talked about supra versus infra. So remember that. A global kind of sign that they may have is headache, altered mental status, and seizures. I've had two friends who had kids with brain tumors, and they both presented with localized seizures in their arms. So I don't know, it's just interesting. Increase intracranial pressure, you're going to look for that. Treatment could involve chemo, radiation. So post-craniotomy, positioning we talked about, you're going to do a neuroassessment Q1 hour after, for 24 hours and report any signs of increased intracranial pressure. SIADH and DI are two potential conditions that can happen post-craniotomy. And interventions to reduce increased intracranial pressure, you should be doing them like head of bed 30 to 45. Post craniotomy, make sure you're checking for the signs of increased intracranial pressure. Medications include steroids. We do give steroids for like post craniotomy or somebody that has a brain tumor. I worked in a pediatric hospice for a while, and I took care of a 13-year-old with a brain tumor. And I started him on dexamethasone. And he was like vented, he had a central line, he had a trach, and he hadn't been talking for weeks. And so I started him on the dexamethasone. And later that day, I asked him a question, and he answered me, and I about jumped a mile because I never heard him talk before. But that brought a lot of joy to the parents that they could hear his voice again, because the tumor had, decreased because of the steroids. So remember your side effects of steroids and phenytonin. I've been asking you about these in class, and you guys seem to have it. With mannitol, remember it's a sugar, so it can crystallize. Use a filter needle, filter on the IV. Don't use if it has crystals. Monitor for fluid overload every hour because it's an osmotic diuretic, so it's going to bring fluid into the vascular system. So we start slowly to prevent fluid overload. They need daily weights, definitely. Okay, now we're going to talk about a TIA, which is a brief interruption of cerebral blood flow. So neurodeficits, so they come in and they present like they're having a stroke, but the deficits resolve in 1 to 24 hours. One TIA indicates high risk for stroke. It's usually treated with aspirin or clopidogrel. So you want to teach them all the health promotion things, okay? And then they may need a cerebral angiography to see where the interruption in the blood flow is. Stroke risk factors include hypertension, diabetes, sleep apnea. Mitral valve stenosis, AFib, and endocarditis can cause clots to form in the heart, and they can shoot up to the brain, so they could have an embolic stroke. Hyperlipidemia, blood control pills, birth control pills, I should say. They have estrogen in them, so they are high risk for stroke. Smoking and alcohol. So there's two main types. There's a ischemic, which is broken down to embolic and thrombotic. The difference between embolic and thrombotic is embolic is going to have sudden signs and symptoms. Hemorrhagic is due to bleeding in the brain caused by hypertension most often. It could be caused by an aneurysm that ruptures, like a subarachnoid hemorrhage. And the hemorrhagic stroke is the one that results in a loss in LOC. Okay, so decreased LOC. So LOC is usually intact in ischemic strokes. So this is AFib, so this would be a common rhythm that somebody would have an embolic stroke, because when you have AFib, clots can form on the inside of your heart. So you remember from Med-Surg 1, you check up for a pulse deficit, 2 nurses. Thrombotic has lower onset, and hemorrhagic can be due to bleeding aneurysms. Okay, health promotion, we kind of talked about this already. Maintain proper weight, no cocaine, be careful on estrogen. Okay, warning signs, be fast. Okay, if you would have to teach this to patients. So if they have a loss of balance, or they have vision problems, or their face gets droopy, or they get weak on one side, and they have trouble talking, it's time to call 911. Stroke assessment. Okay, the goal when somebody comes into the ED is to get the National Institute of Health stroke scale completed. It's a series of things you go through, like assessment, like you do the pronated drift for one, just saying what it is. The scale ranges from 0 to 42. So the higher, you may die. So I think high may die, and I think low is where you want to go. So you want the patient to have a lower assessment on the next time you do it. Okay, low numbers are better. You want them to have a non-contrast CAT scan within 25 minutes. You want to check the glucose and O2 sat, because I talked about that earlier. They're easy fixes. And you want to know the timing, because they need to get thrombolytics. The onset of symptoms has to be within the last 4.5 hours. These are all the herbs that cause bleeding. You'll have to ask your patient before they get thrombolytics if they've had any of these. So garlic, ginger root, golden seal, feverfew I talked about with migraines, ginkgos, all the G's can cause bleeding. Okay, now the interdisciplinary team when somebody has a stroke. You always keep somebody NPO until the swallowing study is done by the speech language practitioner, okay, or pathologist. PT, physical therapies, they're going to help with walkers, canes, quad canes, and wheelchairs. OT is going to help with the ADLs, and social services is going to help with getting them to rehab. They're probably going to go to a rehab hospital after they've been in the hospital. All right, here's the difference between somebody has a right brain damage or right-sided cerebral stroke, right? They're going to have hemiparesis or hemiplegia on the contralateral side. Okay, and you can read this. Left usually has left brain damage has all the A's, aphasia, calcula, all the A's, and the right side is not right in the head. Okay, they're impulsive, they don't recognize anybody, they have poor judgment, they laugh at inappropriate moments, they confabulate. In other words, they're more fun, I'm just saying. Hemianopsia. Okay, so if they say like somebody with a left-sided cerebral brain attack, may have hemianopia in the right eye. So that means when they say they have left-sided hemianopsia, that means they can't see out of the left side of their eye. So you want to put things in their field of vision. So the right side, you want to approach from the right side so the patient can see what's coming, okay? Aphasia, so you got to be patient with people with aphasia. Provide time to respond. Only give them one instruction at a time. Picture board is a good thing. All right, take action, dysphagia. Okay, so they should rest before they eat to prevent aspiration. They should clean their mouths beforehand, okay? Patients should not only focus on eating. No talking, no watching the ball game, no parties in the room. Feed on the unaffected side. So that means the non-weak side. 1 teaspoon at a time. They should not drink and eat at the same time, and they should not use straws. You want to encourage the chin to chest to swallow. Move the head and neck forward. Not the body, but the head and neck. Head to bed 90. Don't place on their back. Supine. Keep upright 45 to 60 minutes. If you're giving oral care, have the suction ready and don't place on their back. Put them on their side. Stroke medications, they're going to be at risk for increased intracranial pressure times 72 hours. Remember that. So they're going to need stool softeners, statins if it's ischemic, heparin and warfarin if it's ischemic, and clopidogrel and aspirin if it's ischemic. If it's hemorrhagic, they're going to get nimodipine, and if they have high blood pressure, they can also get nicardipine. All right, so that does it for alterations in neurological status.